My topic for today is physiology of urine formation, how are diuretics classified, and write briefly the pharmacology of various diuretics in clinical practice. So shall I start?
Yeah, please.
The kidneys are the organs which function by filtering the plasma and removing substance from the filtrate at variable rates depending on the needs of the body. So the kidneys serve multiple functions such as excretion of metabolic waste products and foreign chemicals, regulation of water and electrolyte balances, regulation of body fluid osmolality and electrolyte concentration, regulation of arterial pressure, regulation of acid-base balance, and secretion and metabolism and excretion of hormones. So coming to the functional unit of the kidney, nephrons are the functional unit of the kidney. Each kidney has approximately 1 million nephrons, and each nephron contains the glomerulus, which are the tuft of glomerular capillaries, through which large amount of fluid is filtered from the blood. And it also has a long tubule, which causes the filtered fluid is converted into urine on its way to pelvis of the kidney. The glomerulus, it will be receiving the afferent arteriole, then it has the glomerular capillaries, and from there it will be leaving as the afferent arterioles. So upon leaving glomerulus, glomerular capillary forms the afferent arteriole, and it in turn leads to an anastomosing network of 10 to 25 long peritubular capillaries called vasa recta. And next is the renal tubules. The renal tubules it starts with the proximal convoluted tubule, which is a continuation of the parietal epithelium of nephron. And from the proximal convoluted tubule, a distal short straight length of proximal convoluted tubule will start forming the descending thin limb of the lobe of Henle. And it will make a hairpin turn of 180 degree to ascend toward the cortex, and eventually it becomes the medullary thick ascending limb of lobe of Henle, and then distal convoluted tubule. The most distal end of the nephron is the collecting duct that empties the ultrafiltrate into the renal pelvis and then the ureters. So this is the functional unit of the kidney, which is about the nephron. So coming to the main topic, the formation of urine. The urine is formed by interaction of three different processes. They are glomerular filtration, tubular reabsorption, and tubular secretion. The glomerular filtration is the first process where the formation of glomerular filtrate is dependent on the balance of Stirling forces regulating fluid flux across the filtration barrier. So the glomerular filtration rate, it depends on the glomerular capillary pressure, which is opposed by the hydrostatic pressure in the Bowman space and the colloid osmotic pressure within the glomerular capillaries. So in net, the net filtration pressure is equal to glomerular hydrostatic pressure minus the difference of Bowman's capsule pressure minus glomerular oncotic pressure. So the net filtration pressure value is around 10 millimeter of mercury. The normal glomerular filtration rate is about 180 liter per day. There is a component known as filtration fraction, which is the fraction of blood plasma in the afferent arteriole in the kidneys that become glomerular filtrate. That is around 0.16 to 0.2. And there is a compound of filtration membrane. So the substance filtered from the blood crosses three filtration barriers. It is the glomerular endothelial cells, basal lamina, and filtration slit formed by the podocytes on the Bowman's capsule. There are some factors which regulates the glomerular filtration rate. So there are some renal regulation mechanism, which is divided into myogenic mechanism and tubular-glomerular feedback. And there is neural regulation of glomerular filtration rate and hormonal regulation also. So on the renal type of regulation, there are two mechanisms. One is the myogenic mechanism and the other is the tubular-glomerular feedback. In the myogenic mechanism, the major stimulus is the increased stretching of smooth muscle fibers in the afferent arterial walls due to increase in BP. And this will cause the stretched smooth muscle fibers to contract and thereby causing narrowing the lumen of arterioles. And thereby the final effect will be decrease in the glomerular filtration rate. There is another tubular glomerular feedback where due to high systolic BP, there will be rapid delivery of sodium and chloride to the macula densa, and in turn, it will cause decrease in the release of nitric oxide by the juxtaglomerular apparatus and it causes constriction of afferent arterioles. And the final effect will be decrease in glomerular filtration rate. The other type of regulation, that is neural regulatory mechanism, there will be increase in the activity level of the renal sympathetic nerves, and it will cause release of norepinephrine. And this in turn causes constriction of the afferent arterioles through activation of alpha-1 receptor, and it causes increased release of renin, and thereby causing decrease in GFR. The other two hormonal regulatory mechanisms, one is the angiotensin 2 hormone. It gets released when there is decrease in blood volume or there is fall in BP, and it stimulates the production of angiotensin 2 through the renin-angiotensin system, and it causes constriction of afferent and efferent arterioles. And the final effect will be decrease in the GFR. The other hormone will be atrial natriuretic peptide. There will be stretching of atria of the heart, which stimulates the secretion of the ANP, and it will finally cause relaxation of mesangial cells in glomerulus, and it increases capillary surface area for filtration. And the final effect will be increase in the GFR. In short, the neurohormonal renal regulatory systems can be divided into vasoconstrictor systems and vasodilator systems. So in the vasoconstrictor systems comes the sympathoadrenal system, renin-angiotensin system, aldosterone, and antidiuretic hormone. These all will cause decrease in renal blood flow, decrease in glomerular filtration rate, thereby causing decrease in urine flow and decrease sodium excretion. The vasodilator systems consist of the prostaglandins, kinins, and atrial natriuretic peptide. This will cause increase in renal blood flow, increase in GFR, increase in urine flow, and increase sodium excretion. So that is about the glomerular filtration. And the next is about the renal tubular system. It consists of the tubular reabsorption and tubular secretion. So the reabsorption starts from the proximal convoluted tubule. Even if the GFR is around 180 liter per day, proximal convoluted tubule constitutes for the main part of reabsorption, so that only finally 1.5 liter per day of fluid is excreted as urine. So proximal convoluted tubule, there occurs the main part of reabsorption. So in proximal convoluted tubule, 70% of sodium, water, and chloride ions are reabsorbed. 90% of bicarbonate ions are reabsorbed. Urea around 50%. 100% reabsorption of glucose. 100% reabsorption of albumin, amino acids, phosphates, and sulfates occur. And some substances are secreted in the proximal convoluted tubule. They are organic acids such as penicillin and thiazides, organic bases like histamine and thiamine, EDTA, and hydrogen ions. So the main of sodium reabsorption, it is mainly carried out by active transport of sodium out of the epithelial cells into the lateral spaces by sodium potassium ATPases. So these pump 3 sodium ions out of the cell and 2 potassium ions into the cells. So this causes a fall in intracellular sodium and causes facilitated diffusion of sodium ions from the tubular lumen into the cells via specific carrier proteins. This movement of sodium ions can be coupled to reabsorption of other solutes like bicarbonate, glucose, and chloride. The bicarbonate, the main next coming to bicarbonate reabsorption. So the carrier proteins that facilitate diffusion of sodium into the cells also transport H plus ions out of the cells into the tubular lumen. So in the lumen, H plus ions combines with the bicarbonate to form carbonic acid, and it rapidly dissociates into carbon dioxide and water. This is carried by mainly the carbonic anhydrase enzyme found in the brush border of epithelial cells. This carbon dioxide readily diffuses through the cell membrane into the epithelial cells, where the reaction is reversed, leading to formation of again H plus and bicarbonate ions. The concentration of bicarbonate increases within the cell and it diffuses to lateral spaces before entering the peritubular capillary. So this mechanism allows kidney to conserve body's bicarbonate and plays a key role in acid-base hemostasis of the body. Next one is chloride ion. Chloride is reabsorbed in proximal tubule mainly by two mechanisms. One, there is an antiport mechanism which pumps organic ions into the lumen in exchange for chloride ions. And another is sodium and bicarbonate ions are rapidly reabsorbed in proximal convoluted tubule, and the concentration of chloride ions left in the tubular fluid rises, thereby setting up a concentration gradient for paracellular diffusion of chloride ions. The another main substance reabsorbed in PCT is water. So epithelial cells lining the proximal tubule are very permeable to water molecules. So every solute ion reabsorbed from tubular fluid will reduce the tonicity of the fluid left behind in the lumen and thereby increase the tonicity in the lateral spaces. So water is thus reabsorbed by osmosis via both transcellular and paracellular routes. The next most commonly reabsorbed is glucose. So glucose reabsorption is coupled to the sodium reabsorption. It is mainly done by the glucose co-transporters known as the sodium glucose transporter, which couples movement of sodium ions down their concentration gradient into the cells with the movement of glucose molecules against their concentration gradient into the cells. So this is mainly the reabsorption in proximal convoluted tubule. Next part which is participates in the reabsorption and secretion is lobe of Henle. So in lobe of Henle, the substances which are reabsorbed are 15% of water. That is mainly carried out by osmosis in the descending limb of the lobe of Henle. Sodium almost 20 to 30% is reabsorbed by symporters in ascending limb. Potassium 20 to 30% is reabsorbed by symporters in ascending limb, and chloride 35% is reabsorbed by symporters in ascending limb. That is, these sodium, potassium, and chloride is mainly reabsorbed by the sodium, potassium, chloride co-transporter. Then the 10 to 20% of bicarbonate is reabsorbed by facilitated diffusion, and calcium and magnesium also variable amount is reabsorbed by diffusion. In Lopohelli, mainly the secretion of variable amount of urea can occur. So the main role of Lopohelli in this process is to produce a hypertonic environment within the renal medulla to allow the reabsorption of water by osmosis from the collecting tubules in order to retain water within the body and produce a concentrated urine. As part of this process, Lopohelli also alters the tubular fluid osmolality. At the starting of the Lopohelli, at the starting of the descending limb, the osmolality of the plasma is around 290 milliosmoles, and at the exit of the Lopohelli at the ascending limb, the plasma will be turning into hypotonic, around 90 milliosmolar per kg. And there is some counter current multiplication also contributing for this converting this plasma from isotonic to hypotonic. So mainly the tubular cells of thick part of the ascending limb of Lopohelli, it contains a sodium potassium ATPases, which actively pump sodium out of the cell into the medullary interstitium. This sets up a concentration gradient from tubular lumen into cell for reabsorption of other ions. So reabsorption where sodium potassium chloride specific co-transporter occurs in the ascending limb. The descending limb of Lopohelli is permeable to water and ions, and so it readily equilibrates with the interstitium. The sodium and chlorine reabsorbed from the ascending limb diffuse into the descending limb. Therefore, in effect, an osmotic gradient is established between the descending and ascending limbs of Lopohelli. The constant addition of sodium and chloride to the fluid of the descending Lopohelli leads to a progressive increase in its tonicity until it reaches the tip of Lopohelli. By the time the fluid leaves the Lopohelli, its tonicity has fallen to around 90 milliosmoles per kg. It has started from 290 milli. At the end of the Lopohelli, it will become hypotonic to around 90 milliosmoles per kg. So this is the counter current multiplication mechanism happening in Lopohelli. Coming to the next part of the nephron, it is the distal convoluted tubule, and here the reabsorption occurs in the early distal convoluted tubule and finally in the late distal convoluted tubule and collecting duct. So in the early distal convoluted tubule, the reabsorption of 10 to 15% of water occurs by osmosis, 5% of sodium by symporters, 5% of chlorine by symporters, and variable amount of calcium which is stimulated by the parathyroid hormone. In the late distal convoluted tubule and collecting duct, 5 to 9% of water is reabsorbed by insertion of water channel stimulated by antidiuretic hormone. 1 to 4% of sodium is reabsorbed by the help of sodium potassium pumps and sodium channel stimulated by aldosterone. And variable amount of bicarbonate is also reabsorbed, which depends on the H plus ion secretion, and variable amount of urea is also reabsorbed. In late distal convoluted tubule and collecting duct, secretion of variable amount of potassium and variable amount of H plus ions also occur. So finally, from 180 liter per day of glomerular filtrate, 127 liter is almost reabsorbed in the proximal tubules, and a further 30 liter is reabsorbed in the descending limb of lobe of Henle, leaving 23 liter per day to enter the distal convoluted tubule and collecting ducts. This is still a large volume relative to total body water, and a vast majority of this has to be reabsorbed every day to prevent rapid dehydration. There are some hormonal regulation mechanisms of this tubular reabsorption and tubular secretion also. So the main hormones which helps in the regulation are angiotensin 2, aldosterone, antidiuretic hormone or vasopressin, atrial natriuretic peptide, and parathyroid hormone. So angiotensin 2, exactly what the stimuli which causes for release of angiotensin 2 is either low blood volume or fall in BP, which stimulates the renin-angiotensin system, and it stimulates the activity of sodium hydrogen antiporters in the proximal tubule cells. And finally, it causes increased reabsorption of sodium and other solutes and water, and finally causes increased blood volume and BP. Aldosterone, it is mainly due to increased angiotensin 2 level and increased level of potassium, which promotes the release of aldosterone from adrenal cortex. And the action is it enhances the activity of sodium potassium pump in basolateral membrane and sodium channels in the apical membrane of principal cells in collecting duct. And the final effect will be it causes increased secretion of potassium and reabsorption of sodium chloride, and increases the reabsorption of water, increases blood volume and BP. The antidiuretic hormone or vasopressin will be released when there is increased osmolarity of extracellular fluid or decreased blood volume, and it causes release of ADH from posterior pituitary. It stimulates the insertion of water channel proteins known as aquaporin 2 into the apical membrane of principal cells, and it finally increases facultative reabsorption of water, and it decreases osmolality of body fluids. The atrial natriuretic peptide, it is mainly released by the stretching of atria of the heart, and it suppresses reabsorption of sodium and water in proximal tubule and collecting duct, and inhibits secretion of aldosterone and antidiuretic hormone. It causes increased secretion of sodium in urine, that is natriuresis, and increases urine output, that is diuresis, and thereby causing decrease in blood volume and fall in BP. And next is the parathyroid hormone. It is released when there is decreased level of plasma calcium level, and promotes release of parathyroid hormone from the parathyroid glands. And it causes the opening of calcium channels in the apical membranes of early distal tubule cells. And finally, it will increase the reabsorption of calcium. So this is about physiology of formation of urine.
It's a very exhaustive and very nicely your topic. What I can suggest is you practice to draw expanded diagram of a nephron, starting
Yes, sir.
to the collecting test, and then put lines to section of glomerular pieces, lymphocytes, and these can early collect and collecting that.
Okay.
Try one under the portion. What is happening in the glomerular, how the takes place, and how the how the and sort of exchange on the coming to these can collect that how the serum and there there then finally how the But it is reflected in the answer paper. You can save time, you can have a very clean presentation also.
Yes.
So we have tested all the criteria for the solution. So the drawing combined with the points that I mentioned, mentioned the level each section of the part, I think will be more appealing. Basically, everything like that. Very,
Okay.
very nice. What about the second half of
So, shall we go to next topic?
yeah,
So the next topic is classification of diuretics. So diuretics are drugs which has the primary effect is to increase urine flow and promote diuresis. It can also help in management of hypertension and in cardiac failure also. So the classification of diuretics, they are classified mainly into carbonic anhydrase inhibitors. Example is acetazolamide, loop diuretics, where comes the furosemide, toracemide, azoxamide, bumetanide. Then next classification is thiazides. It comes, example is hydrochlorothiazide, chlorthalidone, and indapamide. Next one is osmotic diuretics. The most common is mannitol. Then next one is potassium sparing diuretics. It is, example is spironolactone, eplerenone, amiloride. Next classification is aldosterone antagonist, and the example for that is also spironolactone. Then dopamine receptor antagonist, in which comes dopamine and phenol-dopam. Then natriuretic peptides. In that comes the nesretide. Next classification is vasopressin receptor antagonist, commonly known as vaptans. Example is tolvaptan. Then neprilysin antagonist, and the last class is aquaporin modulators. So the pharmacology in short of these diuretics, first one is the carbonic anhydrase inhibitors. This mainly acts on the carbonic anhydrase receptors, which are situated on the proximal convoluted tubule, and it results in decreased reabsorption of sodium, bicarbonate, and water. The main clinical uses of carbonic anhydrase inhibitors are mainly in altitude sickness, in the treatment of glaucoma, in idiopathic intracranial hypertension, and it serves as a diuretic also. The most common side effect associated with this is metabolic acidosis. The next class is loop diuretics. It acts by impairing the activity of sodium, potassium, and 2-chloride transport protein in the medullary portion of the thick ascending limb of loop of Henle. So the loop diuretics, they are the most potent diuretics in market now. It has a dose-dependent response, and this is the first-line diuretic in renal impairment. So the side effects associated with loop diuretics are ototoxicity, alkalosis, and hypokalemia. Next class is thiazides, which inhibit sodium chloride co-transporter in the cortical portion of ascending limb of lobe of Henle and in distal convoluted tubule. It inhibits the reabsorption of 5 to 10% of the filtered sodium. It is mainly the first line therapy for hypertension, and the most common side effects are alkalosis, hypokalemia, diabetes, dyslipidemia, and hyperuremia. The next class of diuretics are osmotic diuretics. These mainly act on the proximal convoluted tubule and lobe of Henle. It causes increased plasma and renal tubular fluid osmolality and results in osmotic diuresis. Mannitol is the only one which is currently in use. It is mainly used in the acute management of elevated intracranial pressure, treatment of glaucoma, and in oxygen-free radical scavenging. The side effects of mannitol are volume overload in congestive cardiac failure patients, hypokalemia, hyponatremia, and hypomagnesemia. The next one is potassium sparing diuretics. They act on collecting ducts. It is divided into two groups. One is the pteridine analogs, and the other one is the aldosterone receptor blockers. So in the pteridine analogs comes triamliterone and amiloride. And in the aldosterone blockers comes the spironolactone and eplerenone. So the pteridine analogs prevent sodium reabsorption in the cortical collecting duct, blocking epithelial sodium channels. And aldosterone receptor blockers prevent the synthesis and activation of the aldosterone dependent basal cell sodium potassium ATPase pump. So both mechanisms result in decreased sodium reabsorption without increased potassium secretion. So the use is adjunct to loop diuretics or thiazides, but the side effect is hyperkalemia. Next comes the dopamine receptor antagonist. They act on the D1 receptors in the proximal convoluted tubule and loop of Henle. So it results in natriuresis and increased renal blood flow where their actions on renal tubular dopamine receptors. It increases cyclic adenosine monophosphate formation, resulting in inhibition of sodium H plus exchange and sodium potassium ATPase pump. The uses are to maintain renal blood flow in patients in cardiogenic shock, renal protection, and hypertension treatment in critically ill patients. Then next one is natriuretic peptides. So there are two types of natriuretic peptides. This is atrial natriuretic peptide and brain natriuretic peptide. So atrial natriuretic peptide is normally produced in the atria, and brain natriuretic peptide or BNP is produced in the ventricles or the heart, respectively, in response to myocardial wall stretch. These acts on the collecting duct by blocking basal sodium potassium ATPase channel. The currently available natriuretic peptide market is nesritide. It is mainly used for management of patients with decompensated congestive heart failure. The next class is vasopressin receptor antagonists, commonly known as VAPTENs. They competitively inhibit V2 receptor in the collecting duct, leading to decreased water reabsorption. Tolvaptan is the approved one. It is mainly used for treatment of euvolemic and hypervolemic hyponatremia associated with syndrome of inappropriate ADH, antidiuretic hormone, and also used in the treatment of congestive heart failure and liver cirrhosis. The next classification is aquaporin modulators. They are recently described membrane channels facilitating water movement across the cells in response to osmotic gradient. It acts on aquaporin proteins on the collecting ducts. The final class is neprilysin antagonist. So neprilysin, it is a membrane-bound metalloproteinase with high concentration in cardiac tissues and kidneys. Its function as natriuretic peptide. So natriuretic peptides that stimulate renal secretion of water and are broken down by neprilysin. So this is the pharmacology of some of the commonly used diuretics.
Yeah, that is completed totally classes, right? But from another point, normally the diuretic will come from both area loop there and surely and with regard to hypertension, mostly thiazide as the initial but majority suggest that keeping the years started on AC or ARV over period that challenging and allowed on the Plasma lactose or diabetes more cirrhosis is are the different of cirrhosis. The introduction of this generation with the young guys with the art for the career. The function is not it is not
Okay. Okay, sir.
Thank you, sir. Thank you, Dr. Archana.
Yes, thanks.